Cirrhosis of the liver. Liam P. Burke, MD. Basics description: a chronic disease with inflammation, necrosis, fibrosis, hepatocellular dysfunction, and vascular remodeling potentially leading to liver failure and/or cancer. Epidemiology: predominant age at diagnosis, 40 to 60 years old. Predominant sex, male-female. More women with cirrhosis from alcohol abuse. Liver disease and cirrhosis are the 9th leading causes of death among U.S. adult males. 12th overall. Etiology and pathophysiology: chronic hepatitis C virus, HCV, 26%. Alcohol abuse, 21%. Non-alcoholic steatohepatitis, NASH/obesity, 10%. Hepatitis B virus, HBV, plus hepatitis D infection, 15%. Other, hemochromatosis, autoimmune hepatitis, primary biliary cirrhosis, secondary biliary cirrhosis, biliary atresia, idiopathic biliary fibrosis, primary sclerosing cholangitis, Wilson disease, alpha-1 antitrypsin deficiency, granulomatous disease, e.g., sarcoidosis, drug-induced liver disease, e.g., methotrexate, alpha-methyl-dopa, amiodarone, venous outflow obstruction, e.g., Budd-Chiari syndrome, veno-occlusive disease, chronic right-sided heart failure, tricuspid regurgitation, and rare genetic, metabolic, and infectious causes. Hepatocellular injury results in cellular hyperplasia, regenerating nodules, fibrous changes, and angiogenesis. Distortions in blood flow result in portal hypertension. Genetics: hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency in adults are associated with cirrhosis. Risk factors: alcohol abuse, intravenous drug abuse, obesity. General prevention: mitigate risk factors, e.g., alcohol abuse, screen for hepatitis C, 80% of chronic liver disease is preventable. Limit alcohol consumption and advise weight loss in overweight or obese patients. Commonly associated conditions: HCV, alcohol and drug abuse, diabetes, depression, obesity. Diagnosis. History review: risk factors, alcohol abuse, viral hepatitis, family history of primary liver cancer, other liver disease, or autoimmune disease. Symptoms: fatigue, malaise, weakness. Anorexia, weight loss, weight gain. Ascites/edema, right upper abdominal pain. Bruising, bleeding, hematemesis, hematochezia, melena. Tea-colored urine, clay-colored stools. Edema, abdominal swelling/bloating, pruritus. Bruising, bleeding, hematemesis, hematochezia, melena. Absent/irregular menses, chronic anovulation. Diminished libido, erectile dysfunction. Night blindness. Physical exam may be normal until end-stage disease. Many relate to manifestations of portal hypertension: skin changes, spider angiomas, palmar erythema, jaundice, scleral icterus, ecchymosis, caput medusa, hyperpigmentation, decreased body hair, facial telangiectasias. Hepatomegaly, small, fibrotic liver when end-stage disease, splenomegaly, if portal hypertension, abdominal fluid wave, shifting dullness, ascites, gynecomastia. Dupuytren contractures. Pretibial, presacral pitting edema, and clubbing, especially in hepatopulmonary syndrome, asterixis. Mental status changes, hepatic encephalopathy, muscle wasting, weakness. Fater hepaticus, in severe portosystemic shunting, differential diagnosis. Steatohepatitis. Other causes of portal hypertension, e.g., portal vein thrombosis, lymphoma, metastatic or multifocal cancer in the liver, vascular congestion, e.g., cardiac cirrhosis, acute alcoholic hepatitis. Diagnostic tests and interpretation: initial tests, lab, imaging, aspartate aminotransferase/alanine aminotransferase, AST/ALT. Mildly elevated, typically AST/ALT. Enzymes may normalize as cirrhosis progresses. Elevated alkaline phosphatase, ALP, gamma-glutamyl transpeptidase, GGT, and total/direct bilirubin anemia from hemolysis, folate deficiency, and/or splenomegaly. Thrombocytopenia, 110, 95% specific for cirrhosis, impaired synthetic liver function denoted by hypoalbuminemia, low cholesterol, prolonged prothrombin time, PT, international normalized ratio, INR, and partial thromboplastin time, PTT, coagulopathy of vitamin K dependent clotting factors, 2, 7, 9, X, progressive cirrhosis. Indicated by hyperammonemia, elevated blood urea nitrogen, BUN. Hyperkalemia, and hyponatremia hepatorenal syndrome characterized by creatinine clearance 40 ml/min, or serum CR 1.5, with urine volume 500 ml/day and urine sodium 10 ml equivalent/L. Abdominal ultrasound Q612MO to screen for hepatocellular carcinoma, HCC, Doppler ultrasound or elastography to assess liver parenchyma and Doppler for hepatic/portal vein follow-up tests and special considerations. Consider hepatitis serology, serum ethanol and GGT if alcohol abuse, suspected antimitochondrial antibody to screen for primary biliary cirrhosis, anti-smooth muscle and anti-nuclear antibodies to screen for chronic active, autoimmune, hepatitis transferrin saturation, 50%, and ferritin. Markedly increased, to screen for hemochromatosis, if abnormal, check hemochromatosis, HFE, genetics/mutation analysis. Alpha-1 antitrypsin phenotype screen ceruloplasmin to screen for Wilson disease, if low, check copper excretion, serum copper plus 24-hour urine copper. Alpha-fetoprotein level to screen for HCC, diagnostic procedures/other liver biopsy, required for definitive diagnosis, percutaneous if INR 1.5 and no ascites, otherwise, transjugular, serologic testing gaining use as a surrogate for biopsy, ultrasound-based elastography, non-invasive alternative to liver biopsy, increasing availability, evaluates fibrosis endoscopy if esophageal varices/portal hypertensive gastropathy are a concern, magnetic resonance elastography, most accurate non-invasive method in obese and/or non-alcoholic fatty liver disease, NAFLD. 1. A test interpretation. Fibrous bands and regenerative nodules are classic biopsy features of cirrhosis. Other histologic patterns: alcoholic liver disease, steatosis, polymorphonuclear, PMN, leukocyte infiltrate, ballooning degeneration of hepatocytes, Mallory bodies, giant mitochondria HBV/HCV, periportal lymphocytic inflammation NASH. Same as alcoholic liver disease, steatosis may burn out in advanced disease. Biliary cirrhosis, PMN, infiltrate in wall of bile ducts, inflammation increased in portal spaces, progressive loss of bile ducts in portal spaces, hemochromatosis, intrahepatic iron stores increased via iron stain or weighted biopsy tissue, alpha-1 antitrypsin deficiency, positive periodic acid Schiff bodies in hepatocytes. Treatment: outpatient care except for major gastrointestinal, GI, bleeding, altered mental status, sepsis/infection, rapid hepatic decompensation, or renal failure. General measures: abstain from alcohol, drugs, hepatotoxic medications, and hepatotoxic herbs. 2. B. Pneumococcal, hepatitis A/B, and influenza vaccines. Weight loss, exercise, and control of lipids/glucose. 2. B. Medication. First line: treat the underlying cause first. Note prescribing precautions in decompensated cirrhosis. HCV, goal is to eradicate viral RNA in serum. Latest therapies are genotype dependent. Typical regimens with or without cirrhosis include ledipasvir sofosbuvir, and elbasvir grazoprevir, and sofosbuvir velpatasvir for up to 12 weeks duration. Pegylated interferon, PEG-IFN, is no longer first line. HBV, in compensated cirrhosis with viremia, goal of treatment is to reduce HCC risk and decompensation with 48-week therapy. If decompensated, indefinite therapy recommended. Entecavir 0.5 to 1 mg po daily, tenofovir 300 mg po daily, and telbivudine 600 mg po daily are first line. Adafovir 10 mg po daily second line, PEG-IFN alpha-2A 180 μg/sc weekly for 48 weeks in compensated cirrhosis if not contraindicated. Lamivudine not recommended as first-line agent due to resistance. 3. Benefold. Weight loss of 7–10% to improve histopathologic features. Improved fitness and/or greater than 150 min/week of physical activity improves metabolic and hepatic indices. 2. B. Alcoholic hepatitis. Treat alcohol withdrawal. Madri discriminate function score for risk stratification. Greater than 32 indicates poor prognosis. Patients may benefit from prednisolone 40 mg/day for 28 days with 2 to 4 week taper to reduce short-term mortality. Pentoxifylline for patients who cannot tolerate steroids. Hereditary hemochromatosis. Phlebotomy every 1 to 2 weeks as tolerated to goal. Serum ferritin of 50 to 100 μg/L and then 2 to 6 times per year as needed. Deferoxamine 40 mg/kg/day over 8–12 hours for 5–7 days in dyserythropoietic syndrome and chronic hemolytic anemia to reduce iron overload quickly. Primary biliary cirrhosis. Ursodeoxycholic acid, ursodeol, 13 to 15 mg/kg po divided bid QID with food. 3. A. Bile acid sequestrants are first-line therapy for pruritus. Cholestyramine 4 to 8 grams po bid. Antihistamines. Rifampicin 150 to 300 mg po bid or naltrexone 50 mg/day can be used for pruritus if ursodeol is ineffective. Evaluate and treat for malabsorption, fat-soluble vitamin deficiencies, metabolic bone disease, hypercholesterolemia, hypothyroidism, and anemia. Wilson disease. Initial treatment with penicillamine 1000 to 1500 mg/day po bid QID or trientine 750 to 1500 mg/day po bid TID on empty stomach. Trientine 750 to 1500 mg/day po bid TID is better tolerated. After 1 year, zinc acetate 150 mg/day po bid TID for maintenance, zinc for pre-symptomatic, pregnant, and pediatric populations. Autoimmune hepatitis. Treat if AST or ALT greater than 10 times ULN, or if either greater than 5 times ULN and gamma globulins greater than 2 times ULN with prednisone 30 mg/day times 1 week, then 20 mg/day for 1 week, then 10 mg/day for 2 weeks with maintenance of 5 mg/day with azathioprine 50 mg/day throughout. After induction, treat to normal transaminases. Discontinue maintenance after at least 24 months of treatment if AST and ALT are normal. Esophageal varices. For primary prophylaxis of variceal bleed, propranolol greater than 40 mg, carvedilol 6.25 mg, or nadolol 40 mg po daily, to lower portal pressure by 20 mm Hg, systolic pressure from 90 to 100 mm Hg, and pulse rate by 25%, PPI also indicated for portal hypertensive. Gastropathy ascites/edema, low sodium, 2g/day, diet and spironolactone 100 to 400 mg/day with or without furosemide 40 to 160 mg/day po, torsemide may substitute for furosemide. If serum sodium 120 mol/L, then 1.0 to 1.5 L/day water restriction. If new onset, rule out spontaneous bacterial peritonitis, SBP. If history of SBP, consider SBP prophylaxis, TMPSMXDS daily, norfloxacin 400 mg po daily. Encephalopathy, lactulose 15 to 45 ml bid, titrate to induce 2 to 3 loose bowel movements daily. Combination therapy with rifaximin, 550 mg po bid, is recommended regimen to prevent recurrent hepatic encephalopathy. 4. B. Pruritus, ursodeol, cholestyramine, or antihistamines, e.g., hydroxyzine, renal insufficiency, stop NSAIDs, diuretics, and nephrotoxic drugs, normalize electrolytes, and hospitalize for plasma expansion or dialysis. Prophylactic antibiotics for invasive procedures, GI bleeding, or history of SBP proton pump inhibitor for esophageal varices requiring banding or portal hypertensive gastropathy issues for referral. Evaluate for liver transplant at onset of complications, ascites, variceal bleeding, encephalopathy, jaundice, or liver lesion suggestive of HCC and/or when evidence of hepatic dysfunction develops. Child Turcotte Pugh greater than 7 and model for end-stage liver disease MELD greater than 10. Surgery/other procedures. Varices, endoscopic ligation, 4 to 6 treatments. If acute bleed, use preesophagogastroduodenoscopy e.g. octreotide as vasoconstrictor, transjugular intrahepatic shunt. Tips, second-line or salvage therapy for acute bleed. Ascites, if tense, therapeutic paracentesis every 2 weeks. PRN, caution if pedal edema absent fulminant hepatic failure. Liver transplantation. HCC, curable if small with radiofrequency ablation or resection and transplant. Complementary and alternative medicine. Zinc sulfate 220 mg BID may improve dysgeusia and appetite. Adjunct for hepatic encephalopathy. Milk thistle may lower transaminases and improve symptoms. Dongxin and Huangqi injections may promote improvement. Further studies needed. Admission, inpatient, and nursing considerations. Major GI bleeding, altered mental status, sepsis/infection, rapidly progressing hepatic decompensation, renal failure. Ongoing care. Follow-up recommendations. Regular physical conditioning may help with fatigue. Patient monitoring. Once stable, monitor liver enzymes, platelets, and PTQ612-MO. Patients greater than 55 years with chronic HBV or HCV, elevated INR, or low platelets are at highest risk for HCC. Serial alpha-fetoprotein and liver ultrasound screening. Q612-MO in patients with cirrhosis. MRI with contrast. Best follow-up test for HCC if alpha-fetoprotein elevated and/or liver mass found on ultrasound. Endoscopy at diagnosis and every 3 years, compensated, and every 1 year, decompensated. To screen for varices. Diet: protein, 1.0 to 1.5 g/kg body weight, high fiber, daily multivitamin, without iron. Sodium restriction, 2 g/day, combined with fluid restriction, essential if ascites/edema. Patient education. Educate about when to seek emergency care, e.g., hematemesis, altered mental status, drug, alcohol, and smoking cessation. No cannabis. Update required immunizations. HCV transmission precautions. Prognosis 5 to 20 years of asymptomatic disease from time of initial diagnosis. Model for end-state liver diseases. MELD, score and Child Turcotte Pugh, CTP, score historically used to provide prognostic information. These scores lack contribution of nutritional assessment. Sarcopenia, muscle wasting, suggested as an important predictor of mortality in patients with cirrhosis after onset of complications. Death typically within 5 years without transplant. 5% per year develop HCC. 50% of cirrhotics develop ascites over 10 years. 50% 5-year survival after ascites develop. Acute variceal bleeding is the most common fatal complication. 30% mortality. Median survival after complications, ascites, variceal bleeding, encephalopathy, is 1.5 years. With transplant, 85% survive 1 year. After transplant, 5% annual mortality. 25% of eligible patients receive a transplant because of donor organ shortage. Complications: ascites, edema, infections, hepatic encephalopathy, GI bleeding, esophageal varices, gastropathy, colopathy, hepatorenal syndrome, hepatopulmonary syndrome, HCC, fulminant hepatic failure. Complications after transplant, e.g., surgical, rejection, infections,